Welcome back. In the first part of this episode, we established the foundations: what epilepsy is, how it differs from a single seizure, how abnormal electrical activity in the brain can produce a wide range of symptoms, and why seizure classification matters. Now I'd like to move from theory to practice and ask a more clinical question. When a patient walks into clinic or arrives in the emergency department and says, "I think I had a seizure," what are the first things going through your mind?
The first thing I'm trying to do is decide what exactly happened. In epilepsy, the diagnosis often begins with a careful reconstruction of the event. I want to know whether this was truly a seizure, what type of seizure it may have been, whether it was provoked or unprovoked, whether there were injuries, whether there is any immediate safety concern, and whether the patient needs urgent evaluation. So before I even think about treatment, I'm asking very practical questions. What did the patient feel before the episode? What did the episode look like during the event? How long did it last? What was the patient like afterward? Was there a witness? Were there any triggers, such as sleep deprivation, infection, alcohol withdrawal, missed medication, or metabolic illness? That sequence, before, during, and after, is one of the most useful frameworks in seizure history taking. Yale's recent Epilepsy Explainer and Mayo Clinic's Diagnostic Guidance both emphasize that understanding where seizures come from, how they present, and what type they are is central to management, and that evaluation begins with the clinical history before tests are interpreted.
Let's start with the before. What might a patient say in the moments leading up to a seizure?
Some patients describe no warning at all. The seizure may seem to come out of nowhere, but others report a very characteristic, stereotyped pre-seizure experience. Sometimes this is what people call an aura, though from a neurological perspective, that aura may itself be a focal aware seizure. The descriptions can vary, but common examples include a rising sensation in the stomach, a sudden wave of fear or panic, déjà vu or an intense feeling of familiarity, a strange smell or taste, visual distortions or flashing lights, tingling or numbness in one limb, a sense that sounds are becoming distant or unreal, sudden difficulty finding words. The key feature is often stereotypy. Patients may say, "It always starts exactly the same way." That matters because repeated, highly similar episodes suggest a recurring neurological event, rather than a vague, nonspecific symptom. Yale's recent Epilepsy Explainer similarly describes focal symptoms such as jerking of part of a limb, and notes that seizures can affect many functions depending on which brain areas are involved.
So if a patient says, "Every few weeks I get the same rising feeling in my stomach, then I become confused," that's the kind of history that should immediately make us think carefully about focal epilepsy.
Exactly. The pattern is very informative.
Now let's move to the event itself. Often the patient can't describe that part very well, especially if awareness is impaired. So how valuable is the witness account?
It can be invaluable. In some cases, it's the most important part of the history. A witness may tell us things the patient simply cannot know, whether the patient stopped responding, whether the eyes deviated to one side, whether there was lip smacking, repetitive hand movements, head turning, stiffening, jerking, vocalization, cyanosis, or a progression from a focal event to a generalized convulsion. A witness can also help us estimate duration. That's important because a 5-second absent seizure is very different from a 2-minute generalized tonic-clonic seizure, and both are different again from a prolonged convulsive seizure that raises concern for status epilepticus.
What kinds of details are especially helpful from a witness?
I usually want to know how the event began. Did one arm jerk first? Did the patient suddenly stare? Did they slump? Whether awareness was impaired, could the patient respond to their name? Whether there were automatisms, lip smacking, chewing, fumbling, repetitive picking movements. Whether the head or eyes turned to one side. Whether there was bilateral stiffening or jerking, suggesting wider spread. How long the event lasted. What the recovery looked like. Confusion, sleepiness, headache, or muscle soreness. Those details help us classify the seizure and sometimes tell us something about seizure severity and spread. For example, a patient who was deeply exhausted and confused after a generalized tonic-clonic seizure has had a very different event from someone who has a brief focal aware sensory seizure and remains fully alert throughout.
So when you hear she was not herself for half an hour afterward, that's clinically meaningful.
Absolutely. It's one of those details I never want omitted from the history.
What about injuries? Is that something you ask about routinely?
Yes, because injuries tell us two things. First, they tell us about the severity and real-world risk of the event. Second, they sometimes help us infer what happened during the seizure. I ask about tongue biting, falls, head injury, shoulder dislocation, urinary incontinence, burns from cooking, injuries from collapsing in the bathroom or on stairs. And I also ask about where the seizure occurred. Did it happen while driving, while swimming, while carrying a baby, while crossing a road? Seizures are not only neurological events, they are safety events. That's why seizure counseling always includes practical precautions.
So even at the history-taking stage, you're already thinking about risk reduction.
Exactly. If someone has had a loss of consciousness event in the shower, for example, I'm already thinking about bathing safety, supervision, and whether they need urgent restrictions until the picture is clearer.
Now let's look at the other side of the coin. Are there certain histories where you think this may not be epilepsy at all?
Yes, not every blackout or unusual episode is a seizure. Some events turn out to be syncope, especially if there is a clear trigger such as pain, dehydration, prolonged standing, or overheating, followed by lightheadedness and brief collapse. Some are panic attacks, some are sleep-related events, some are movement disorders, and some are psychogenic non-epileptic events. That doesn't mean the patient is faking symptoms. It simply means the mechanism may not be epileptic electrical activity in the brain. Distinguishing those possibilities is one reason we have to be so careful with the history, and why we often need EEG, imaging, or video monitoring to support the diagnosis. Mayo Clinic's diagnostic pages also emphasize that EEG and video EEG can help distinguish epilepsy from other conditions with similar symptoms.
So let's imagine that after the history, epilepsy is high on the differential. How do you approach the formal diagnostic workup?
I'd say the workup has two broad goals. First, we want to determine whether the patient is likely having epileptic seizures, and if so, what type. Second, we want to understand why they are happening. Is there a structural lesion, a genetic syndrome, a prior brain injury, a scar, stroke, tumor, malformation, infection, or inflammatory process? Or is the MRI normal and the diagnosis being driven mainly by the clinical history and EEG pattern? Yale's 2026 Epilepsy Explainer makes exactly this point. Diagnosis matters because there are many different ways to treat seizures, and understanding where they come from and what brain functions they affect has a direct correlation with what can be done.
Before we get to tests, what does the bedside evaluation include?
A full medical and neurological history, a review of medications and substances, family history, developmental history where relevant, and a neurological examination. I want to know age at first seizure, frequency and pattern of events, any childhood febrile seizures, history of head trauma, stroke, CNS infection, brain surgery or developmental delay, family history of epilepsy, sleep deprivation, alcohol use, substance exposure, or medication non-adherence, whether there are multiple event types rather than one. The neurological examination may be completely normal between seizures, but it can still reveal focal deficits or clues to an underlying structural problem.
So the workup isn't just order an EEG and see what happens.
Not at all. The EEG is important, but it's only a piece of the puzzle.
Let's talk about EEG then, because it's probably the investigation people most strongly associate with epilepsy. What exactly is it doing?
An EEG, or electroencephalogram, records the brain's electrical activity using electrodes placed on the scalp. We're looking for patterns that support epilepsy, such as epileptiform discharges, or for actual seizures if they happen during the recording. The EEG can help in several ways. It may support the diagnosis of epilepsy. It may suggest whether the seizures are focal or generalized. It may point to a particular brain region. It may help distinguish epilepsy from some non-epileptic events. Yale's recent Epilepsy Explainer describes EEG as a way of measuring the brain's electrical signals using electrodes on the head to help determine where seizures are coming from. Mayo Clinic likewise notes that EEG is the most common test used in epilepsy diagnosis, and that the brainwave pattern can help classify seizure type and estimate recurrence risk.
That sounds straightforward, but I know there's an important caveat here. A normal EEG does not necessarily exclude epilepsy.
Exactly, and this is a crucial teaching point. EEG is incredibly useful, but it is not perfect. Seizures are intermittent events. Interictal epileptiform abnormalities may or may not appear during the recording, so a patient can absolutely have epilepsy and still have a normal routine EEG. That's why we interpret the EEG in context. A normal EEG does not erase a convincing seizure history. Conversely, an abnormal EEG also has to be interpreted carefully in the context of the patient's clinical story.
So the mistake would be to treat the EEG as a yes or no machine.
Exactly. It's a powerful tool, but it's not a substitute for clinical reasoning.
What do you do if the routine EEG is unrevealing, but you still strongly suspect epilepsy?
That's where longer monitoring becomes useful. Depending on the case, we might use ambulatory EEG where the patient is monitored at home over a longer period, video EEG monitoring, often in hospital where we record both the EEG and the patient's behavior simultaneously. Video EEG is especially valuable when we're trying to capture an actual event. It lets us correlate the patient's movements, awareness, and clinical behavior with the electrical changes in the brain. Mayo Clinic explains that ambulatory EEG can record seizure activity over days at home, while video EEG in hospital can capture seizures as they occur and help determine what type they are, or rule out other conditions. Yale's clinical epilepsy program also emphasizes continuous brain and video monitoring, including epilepsy monitoring units for adults and children.
So if there's uncertainty, say whether a patient's recurrent spells are epileptic or not, video EEG can be transformative.
Absolutely. In some patients, it changes everything because for the first time, we're not guessing what the event looked like. We're seeing it and recording the brain activity at the same time.
Let's move to imaging. Where does MRI fit into the evaluation?
MRI is one of the most important tools we have, particularly in focal epilepsy. The purpose is to look for structural abnormalities in the brain that might explain the seizures. For example, an old stroke, cortical dysplasia, hippocampal sclerosis, a tumor, a vascular malformation, scar tissue from prior injury or infection. Mayo's 2026 explainer says very clearly that a brain MRI is one of the most useful tools in evaluating epilepsy because it helps identify structural abnormalities, such as stroke or brain tumors. Mayo Clinic and Johns Hopkins make the same point. MRI can reveal damaged tissue or lesions that may correspond to a seizure focus and shape treatment planning.
So if the EEG tells you something about electrical behavior, the MRI tells you whether there's a structural reason behind it.
Exactly. One is functional information about electrical activity, the other is anatomical information about the brain itself.
Beyond EEG and MRI, what other tests might come into play?
That depends on the case, but possibilities include blood tests to look for infection, metabolic abnormalities, autoimmune clues, or other contributors. Genetic testing, especially in children or in syndromes where inherited causes are suspected. PET or SPECT imaging in surgical evaluations. High-density EEG for more precise localization in some patients. Neuropsychological testing when we're assessing cognition and planning surgery. Mayo Clinic's epilepsy and epilepsy surgery guidance discusses many of these tools, including high-density EEG, PET, SPECT, and inpatient monitoring when a surgical workup is needed. Yale's Epilepsy Center also describes phased-based evaluations that integrate history, cognitive testing, electrophysiology, and advanced imaging such as MRI, PET, and SPECT.
Patients often ask a very understandable question. If my MRI is normal and my EEG doesn't show much, does that mean I don't have epilepsy? How do you answer that?
I tell them that normal tests do not automatically exclude epilepsy. Some people have epilepsy with no obvious structural lesion on MRI, and some may not show epileptiform abnormalities on a routine EEG. The diagnosis may still be strongly supported by the clinical history, by witness descriptions, by repeat or prolonged EEG monitoring, or by the overall pattern of events. At the same time, I also explain that uncertainty is sometimes real. In medicine, we occasionally need time, repeated observation, or additional monitoring before we can be confident. So I try to be honest without being dismissive. I might say, your tests so far do not prove epilepsy, but they do not rule it out either. We need to keep the clinical picture in view.
That's a very balanced answer, and it sounds much more realistic than pretending every diagnosis is obvious after one clinic visit.
Exactly. Epilepsy diagnosis can be very clear in some patients and genuinely nuanced in others.
Let's say the diagnosis is established, or at least the treating team is sufficiently convinced to begin management. What are the main goals of treatment?
The ideal goal is simple to say, and sometimes hard to achieve: complete seizure freedom with minimal side effects. But there are really several goals operating at once. Stop seizures or reduce them as much as possible. Avoid treatment-related harm, including cognitive or mood side effects. Improve safety and quality of life. Prevent seizure-related injury and emergency admissions. Match treatment to seizure type and underlying cause. For many patients, treatment begins with medication. Mayo Clinic notes that most people with epilepsy can become seizure-free with one anti-seizure medicine, while others may need more than one, and that choosing the right drug depends on seizure type, age, comorbidities, and other medications.
So, anti-seizure medication is usually the first-line approach?
Yes, for most newly diagnosed patients, the first major treatment decision is selecting an anti-seizure medication, sometimes called an anti-seizure medicine, or ASM. The choice is individualized. We consider the type of seizure, whether the epilepsy appears focal or generalized, the patient's age, pregnancy potential, and reproductive counseling were relevant, kidney or liver disease, psychiatric comorbidity, cognitive profile, other medications and potential interactions, the patient's lifestyle and ability to adhere to a dosing schedule. So there isn't one best epilepsy drug for everyone. The right medication for one patient may be the wrong one for another.
And I assume that's one reason the exact seizure classification matters so much, because the medication choice depends on it.
Exactly. If we classify the seizure incorrectly, we may choose a suboptimal drug, and in some cases, certain medications can aggravate particular seizure syndromes. How do you typically begin treatment? Often with a single medication at a relatively low dose, increasing gradually as needed. We want to find the lowest dose that controls seizures without causing unacceptable side effects. Mayo Clinic describes this same general principle. Start with one medicine, often at a low dose, and raise it gradually until seizures are well managed.
So it's not just prescribe and forget, it's a process of adjustment.
Very much so. Follow-up is essential. We review seizure frequency, side effects, adherence, mood, cognition, and whether the patient is actually able to live their life more safely. What kind of side effects do patients commonly struggle with? It varies by medication, but common complaints include fatigue or drowsiness, dizziness, poor concentration, slowed thinking, irritability or mood changes, imbalance, nausea, blurred vision. Some drugs have more specific risks, and there are rarer but important complications such as severe rash, liver problems, depression, or suicidal thoughts depending on the medication and the patient. Mayo Clinic specifically lists side effects such as fatigue, dizziness, skin rash, coordination problems, speech problems, and memory or thinking difficulties, along with rare, serious psychiatric or inflammatory complications.
That must make treatment conversations quite delicate, because the patient may feel caught between seizures on one side and side effects on the other.
Exactly. That's why epilepsy treatment is often about balancing seizure control with tolerability. A medication that technically reduces seizures but leaves the patient too sedated to function may not be a long-term solution.
Let's talk about adherence, because I imagine it's absolutely central.
It is. A patient may have an excellent medication on paper, but if they miss doses regularly, seizure control may be poor. And unlike some conditions where a missed tablet may not matter immediately, in epilepsy, missed doses can have direct consequences: breakthrough seizures, injury, loss of driving privileges, emergency visits, or hospitalization. So I talk openly about adherence. What time of day is realistic for the patient? Do they need once daily dosing if possible? Can they use alarms or pill organizers? Are cost or pharmacy access barriers causing missed doses? Do side effects make them avoid the medication? Mayo Clinic's patient guidance strongly emphasizes taking anti-seizure medicines exactly as prescribed and not stopping them abruptly without medical supervision.
That's a very practical point, and it's one of those areas where medicine overlaps with real life.
Exactly. A treatment plan only works if it fits the patient's actual life.
What happens if the first medication doesn't work?
Then we reassess. Did it fail because it truly didn't control the seizures or because the patient couldn't tolerate it? Was the diagnosis correct? Was the seizure classification correct? Was adherence good? Were there triggers such as sleep deprivation or alcohol use? Depending on the situation, we may increase the dose, switch to a different medication, use a second medication in combination, reevaluate the diagnoses and monitoring data. But there's a very important threshold in epilepsy care, and that brings us to the concept of drug-resistant epilepsy.
Yes, let's define that carefully. What do clinicians mean by drug-resistant epilepsy or medically refractory epilepsy?
In practical terms, we use that phrase when seizures continue despite appropriate trials of anti-seizure medication. A commonly used clinical benchmark is failure of 2 appropriately chosen and appropriately used anti-seizure medications to achieve sustained seizure freedom. That doesn't mean the patient is hopelessly untreatable. It means we should stop thinking only in terms of trying one more routine medication and start asking whether the patient needs a specialized epilepsy center evaluation. Yale's epilepsy program specifically describes care for medically intractable epilepsy, and Yale's epilepsy surgery page notes that for patients whose seizures are not well controlled by drugs, particularly after trying 2 or more medications, identifying and ablating or stimulating the seizure focus may be the best next step. Mayo Clinic similarly notes that about a third of patients continue to have seizures despite treatment, and may be candidates for surgery or device-based therapies.
Why is that threshold so important?
Because if a patient has failed 2 well-chosen medications, the likelihood that a third or fourth routine drug trial will suddenly cure the epilepsy becomes lower. At that point, it's often more productive to ask a different question. Is this person a candidate for surgery, invasive monitoring, or neuromodulation? The danger is that patients can spend years cycling through medication after medication without anyone stepping back and asking whether they need a comprehensive evaluation at an epilepsy center.
So the risk is not just uncontrolled seizures, it's also lost time.
Exactly. Lost time, lost independence, repeated injuries, avoidable emergency admissions, and a prolonged reduction in quality of life.
What does a referral to a comprehensive epilepsy center actually add?
It adds depth and precision. A specialized center can offer prolonged video EEG monitoring, advanced epilepsy protocol MRI, PET or SPECT when appropriate, neuropsychological testing, multidisciplinary review by epileptologists, neurosurgeons, neuroradiologists, neuropsychologists, and other specialists, assessment for surgery or device therapy. Yale's Epilepsy Center describes exactly this kind of comprehensive, phase-based evaluation, bringing together the patient's history, electrophysiology, cognitive testing, and advanced imaging to determine concordance and decide whether surgery or another intervention is appropriate.
So it's not just a second opinion, it's a fundamentally more detailed workup.
That's right. The goal is to understand the epilepsy at a much higher resolution.
Let's talk about surgery.
When people hear brain surgery, they often assume it's a last resort or almost something unthinkable. But in epilepsy, surgery can be a very important option, can't it?
Yes, surgery is not appropriate for everyone, but for the right patient, it can be life-changing. In general, surgery is considered when seizures are drug-resistant. The seizures appear to arise from a specific brain region. That region can be treated without causing unacceptable loss of critical function, such as language, vision, or movement. Mayo Clinic's epilepsy surgery guidance explains this process very clearly, including baseline EEG, video EEG, MRI, PET, SPECT, and sometimes invasive EEG monitoring with surgically placed electrodes when non-invasive tests don't provide enough information.
So, localization isn't just academic. It determines whether surgery is possible and how risky it might be.
Exactly. It's the foundation of the whole decision.
And if the seizures are real and disabling, but the patient isn't a good candidate for resective surgery, what then?
Then we may consider neuromodulation or device-based therapy. The main examples include vagus nerve stimulation, VNS, deep brain stimulation, DBS, responsive neuromodulation, RNS. These are not magic cures, but for selected patients, they can reduce seizure frequency and improve quality of life when medication alone is not enough. Mayo Clinic describes vagus nerve stimulation as a device implanted under the chest skin that stimulates the vagus nerve and can reduce seizures. DBS as implanted electrodes that deliver pulses to specific brain targets, such as the thalamus. And RNS as a pacemaker-like system that analyzes brain activity and delivers stimulation when seizures begin. Yale's recent materials also discuss closed-loop neuromodulation as an option in some patients who are not good candidates for resection.
Could you explain responsive neuromodulation in simple terms for our listeners?
Of course. The idea is to implant a device that monitors brain activity continuously. When it detects a pattern suggesting a seizure is starting, it delivers electrical stimulation in an attempt to interrupt that seizure before it fully develops or spreads. So instead of waiting for the seizure to happen and then dealing with the consequences, the system tries to respond in real time. That's why people often describe it as a closed-loop system, sensing, analyzing, and responding. Mayo Clinic explicitly describes responsive neuromodulation in those terms, an implantable pacemaker-like device that analyzes brain activity patterns, detects seizures as they start, and delivers stimulation to stop them.
So it's a perfect example of how epilepsy care is moving from passive observation toward active brain network intervention.
Exactly. And for some patients, especially those whose seizures arise from eloquent cortex or from regions that cannot simply be removed, that's incredibly important.
I imagine that for patients, the moment you say, you may need an epilepsy center evaluation, or we should discuss surgery or a device, that can be emotionally difficult.
It can be. Patients may hear the word surgery and immediately imagine catastrophe, or they may feel discouraged, as though failing medication means they've somehow failed treatment. So part of our job is to reframe that conversation. I often say, this is not bad news in the way you may think. It means we have reached the point where a more specialized evaluation may offer options beyond simply adding more tablets. The goal is to move from repetitive trial and error toward a more precise strategy.
So the referral is not a sign of defeat, it's a sign that the case deserves a higher level of analysis.
Exactly. And sometimes that higher level of analysis is what finally changes the patient's life.
Let me pause again and draw together the major clinical themes from this second installment. We began by looking at how epilepsy presents in real patients. We said that seizure history taking should be organized around before, during, and after the event. Before the seizure, patients may describe stereotyped focal symptoms, such as a rising abdominal sensation, fear, déjà vu, unusual smells, or visual changes. During the event, witness accounts can reveal loss of awareness, automatisms, head turning, focal motor onset, or progression to generalized convulsions. And afterward, the post-sictal period with confusion, fatigue, headache, amnesia, or focal weakness can provide important diagnostic clues. We then moved into diagnosis, emphasizing that the workup has two goals: identifying whether the patient is having epileptic seizures and understanding why they are happening. We discussed the central role of history and neurological examination, the usefulness of EEG in identifying epileptiform patterns and seizure type, the value of ambulatory or video EEG when events need to be captured, and the importance of MRI in detecting structural causes such as stroke, tumor, or hippocampal sclerosis. Yale's 2026 Epilepsy Explainer and Mayo's guidance both stress that understanding seizure origin and type directly shapes treatment, and that MRI and EEG are core tools in that process. Finally, we turned to treatment. We said that the ideal goal is seizure freedom with minimal side effects, and that most patients begin with anti-seizure medication tailored to seizure type, age, comorbidities, and practical factors, such as adherence. We also emphasized a key threshold in modern epilepsy care. If a patient has failed 2 appropriate medication trials, we should think seriously about drug-resistant epilepsy and referral to a comprehensive epilepsy center. At that stage, the patient may need advanced evaluation for surgery, video EEG localization, or device-based neuromodulation, such as VNS, DBS, or responsive neuromodulation. Yale and Mayo both explicitly describe these pathways for medically refractory epilepsy. Doctor, before we stop this section, what is the single most important message you'd want a trainee or an OET candidate to remember about difficult epilepsy cases?
I'd say this. If seizures continue despite treatment, don't fall into the trap of thinking the only option is to keep trying random medications forever. Ask whether the diagnosis is secure, whether the seizure type is correctly understood, and whether the patient now needs specialist epilepsy center evaluation. That question can change the entire course of care.
That's an excellent note to end on.